Okay, I think we're going to go ahead and get started. My lecture will probably only take about an hour and a half, so I'll get you out a little bit earlier today. Today we're going to be talking about a number of things, but it's whatever we didn't cover in the book from the previous 3 lectures. So we're going to be jumping around a little bit. I apologize for that. Some things that we're going to be covering today: asthma. We're going to be going into steroids, thrombolytics, and then we're going to touch on mannitol, nematop, and then warfarin too. So like all the other lectures, let me know if you have any questions during it. Go ahead and start out right away and ask me questions, and we'll just answer them as we go through. Okay? Any questions on the previous 3 lectures at all before I move forward? Okay. All right, today, have you guys had a lecture on asthma at all? No, never have. Okay, good. So some of this stuff is going to be, maybe some of it's going to be a little basic. Hopefully it'll kind of tie together some of the drugs that we're going to be using. But when we talk about asthma, you guys are probably pretty familiar with nebulized treatments of various drugs. But there's also like meter dose inhalers, dry powder inhalers, etc. that you can use. So when we talk about the drugs itself, when you deliver the drug specifically to the site, you get a more rapid response than actually like taking a pill or having an injectable drug, having it circulate around the system, and then actually eventually go into the lungs. Does that make sense to everyone? So with the development of drugs and development of products to deliver these drugs, the particle size is really important. Now, this may seem like it's really, really weird, but if the particle size of the drug that is delivered to you is too large, the particle is actually going to fall out into the oral pharynx and it's not going to get down into the lungs. Okay? So the optimal size is anywhere from 1.5 to anywhere from 5 to 10 microns. So we're talking about a really, really small drug, really, really small particles. And these small particles themselves actually get down into the lungs and they cause bronchodilation. So the most common drug / device for treating asthma is what? A meter dose inhaler, right? Everyone's kind of seen them in the field. This delivers approximately 15 to 50% of the actuated dose actually gets into the lungs. So it's a pretty good device at, targeted approach. You don't have to worry about taking a syrup or a pill to get it, but it works pretty quickly too, right on the bronchioles, and helps dilate it. It's portable, it's convenient, it's easy for the patient to kind of carry around with them. Now, last year, around December of 2011, there was a ban on CFC propellants. Is everyone kind of aware of this or not? So they reformulated all of the inhalers. So instead of the chlorofluorocarbons, that's what CFC stands for. They're bad for the environment. They break down the ozone. They're HFCs, which is hydrogenated fluorocarbons. So less of the chlorine ring itself. When they did that, a lot of them went back to brand names. A lot of them got more expensive. There's about 3 of them on the market right now. There's Ventolin, ProAir, and then there's Proventil. So the appropriate way and the proper way of actually delivering a meter dose inhaler to you is not to actually put your mouth around the inhaler itself, but hold it away from your mouth. Could be up to 6 inches, but somewhere around 3 to 4 inches, and actually press the chamber down as you're inhaling itself. Now, for patients, sometimes it's really hard to get that coordination down, especially if it's a pediatric patient. So I'll talk a little bit more about different devices that has kind of come up that helps you deliver the full dose. Now, probably the second most common inhaler out there is what's called a dry powder inhaler. Does everyone know what those are? Yes? Some people are shaking their heads yes, some people are shaking their heads no. So the difference between a dry powder inhaler and a meter dose inhaler is that the dry powder inhaler itself doesn't have a propellant in it. So you won't hear things come up about CFCs or HFAs actually in the dry powder inhalers, because how the drug actually gets into your lungs is the inspiratory breath that you take while having your lips around the device itself. So a lot of these devices, you'll click them to activate the dry powder inside. Make sure not to tip the product over because then all the drug will fall out. Hold it level. Put your lips around the inhalation device itself, and what you'll do is the speed at which you inhale the drug itself is the proper way of actually getting the drug into your lungs. So the dry powder inhalers, you would take a breath of anywhere from 1 to 2 seconds, very, very quickly, the breaths. The meter dose inhalers are anywhere from 3 to 5 seconds. So when you tell patients or when you talk to patients, make sure that they, the meter dose inhalers and the dry powder inhalers, they kind of get the techniques and how to use the drugs kind of mixed up back and forth. And then the other route of delivering these drugs into your lungs is the nebulizers, which actually are not that efficient at delivering the drug itself. They actually only deliver about 2 to 15% of the dose. So that's why the doses in which you would give via nebulizer are a lot higher than what the meter dose inhalers are or the dry powder inhalers. Kind of make sense, everyone? Okay. So some meter dose inhalers have counters on them. Some actually don't. Here I've given an example of another product that your book doesn't talk about, but pure Albuterol. The brand name is Max Air, and I'll show you a picture of that. This product actually has a breath actuated device, so you don't have to worry about pushing down on the meter dose inhalers to get the drug itself. As soon as you start to breathe in, the canister is actually dispensed and the drug is actually delivered to you. So a little bit different. And there was a product over the counter, Primatene Mist. Has anyone heard of that? That's actually gone away. I don't know if they're going to reformulate that product at all or not, but you'll see that slowly going away over the next year or so. So this is an example and a picture of a dry powdered inhaler, probably the most common on the market. It's called Advair. Has everyone seen this before? So the device that I was talking about, this little slide mechanism, you slide it back and it clicks, and then that actually punctures a little blister pack within the inhaler itself and then exposes the dry powder. So like before, when the patients use this product itself, they have to inhale at a really rapid speed over 1 or 2 seconds to actually get the drug into lungs and deep into lungs so it works. This is a combination of a long-acting beta-2 agonist and a steroid in itself. This is an Advair meter-dosed inhaler, okay? It has the canister right here, which has propellant in it along with the 2 drugs, long-acting beta-2 agonist and a steroid, but the propellant itself is the one that's going to carry the drug into the lungs along with this slow inspiratory rate of about 3 to 5 seconds or so. And then this is just a picture of Albuterol, specifically Ventolin. It has a counting device on the side, so it actually counts down to tell you how many actually breaths are left in it or actuations are left. A lot of patients get confused with how often or to get their Ventolin or Proventil refilled, and it can be kind of confusing for patients because who counts, you know, how many puffs that they take out of an Albuterol inhaler? No one really counts. The only way that you can really kind of tell is, you know, on a daily basis, if you start using your inhaler maybe a couple times a day or 6 times a day, and you sort of write it on a calendar, then at the end of the month you can tally up how many actuations that you've used. Sometimes the inhalers themselves, they have what seems like drug left in them. It's not actually drug itself. Sometimes it's actually the propellant itself. So the patient may be using this inhaler, there's no drug left, just the propellant itself, and they can't get relief from their quote-unquote asthma attack. This is a picture of this is a Max Air inhaler. This one itself, you don't have to worry about pressing down on the canister to deliver the drug itself. So this is in its normal state right here. When you want to deliver the drug to you, you'd flip this little white cap up right here, and then take a breath. And this actually has propellant in it, so the proper way of doing it would be 3 to 5 seconds of inhalation. This is a short-acting beta-2 agonist, so it's not different than the long-acting ones that I showed a picture of before. This kind of just highlights before the breath in which you would take 3 to 5 seconds. Also, you want to hold your breath for 10 seconds afterwards. Wait a minute in between puffs. That's the proper way of doing it. That way the medication can actually settle in your lungs, help open up your airways. So the next breath that you can possibly deliver may get a little bit deeper into your lungs and your airway. Make sense? Okay. So you see sometimes like spacers. Does everyone know what a spacer is? We're talking about meter dose inhaler. It's like a holding chamber that patients will hook up to only a meter dose inhaler. So the dry powder inhalers, you actually don't have spacers with them because it's hard to get the dry powder into your lungs if you have a whole nother space around there and there's a whole bunch of air leaks on itself. So the holding chambers are good for patients who don't have that coordination. They can actually deliver the drug in itself into that holding chamber and then take several puffs out of that holding chamber or spacer to help get the medication into their lungs. A lot of times you'll see children using them, or you'll see children having face masks itself. So common inhaler mistakes that patients have, sometimes they don't breathe outwards before they start taking a breath of the meter dose inhaler. Sometimes their speed is not correctly, so they inhale slowly, too slow, or even with the meter or with the dry powder inhaler, they'll inhale slowly. Most of the drug actually gets deposited on the tongue and in the mouth. They don't press down on the inhaler at the start of the inhalation, and then sometimes they actually they don't press down on it once they're inhaling. So all of it has to do with coordination. Sometimes this that max air helps out with patients. Sometimes it's just a matter of practice, 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 and patients will get used to it. So severe asthma, when you're in the field, what's your primary goal for treating patients with severe asthma? Okay, dilate the bronchioles, all right. That's pretty much one goal itself. Correction is significant hypoxemia. You know, you want to do a pulse ox right away, see how what their pulse ox is. Rapid reversal of the airflow obstruction, if there's any sort of obstruction there. Beta-2 agonists, anything like that that you would give right away will open up the airways and help with hypoxemia too. Future though, what you'd want to do is you want to reduce the likelihood of relapse on these patients. And then you also, when they come into the ER, we usually give them a written plan of what they need to do to manage their asthma on an outpatient basis. And they usually have these peak flow meters. You guys familiar with peak flow meters? Okay. That measures their FEV1, okay? Their forced expiration volume with one specific breath. And they usually have goals that puts them in specific ranges. And we usually call it a green, a yellow, and a red. And then with those goals and with those colors, those zones, there's specific instructions of what the patients need to do, whether it's they need to move on to taking oral steroids, or if they need to up how many times a day that they're actually using the rescue inhaler, or specifically turn to a long-acting like beta-2 agonist with an inhaled steroid to help correct some of their asthma exacerbations. Okay, so I've just written down some of the risks associated with life-threatening risks associated with asthma. So these are just here for you. Patients that are on chronic steroid courses or a current course of steroids, they're actually at higher risk of having a life-threatening exacerbations. Sometimes because a lot of the inflammation that's associated with asthma is not currently under control, and it'll progress actually as the patients are exposed to either really, really humid air like today, or any sort of pollen or anything actually that trips off their asthma exacerbations. So with patients, I mean, the key is to recognize actually their deterioration of these patients and actually reversal of the lung function. It may take a while for the whole lung function to kind of reverse on its own, even though you're giving them constant drugs, even though you're giving them beta-2 agonists, even though you're giving them steroids. It takes a while. You know, sometimes you'll see reversal of it anywhere from 12 to 24 hours later. Sometimes it can take up to 3 to 4 days for complete restoration of the lung function. So, what are some non-pharmacological treatments for asthma? Is there anything? What's that? Cold coffee. Okay. So caffeine in itself can help with bronchodilation. I think in someone who has an asthma exacerbation, I think giving them fluids or coffee like that. If you don't have anything else around, great. But if you're on your rig or if you have drugs, obviously the drugs that you have and that you carry are going to be better than giving them cold coffee. Anything else? So I've highlighted some of these things. I mean, you don't want to add extra fluid to these patients, okay? They have a large amount of capillary leak that's going on with their lungs. So all these inflammatory mediators are coming out and they're restricting the airflow and the airways even more. They're having a lot of fluid leaking out. Any additional fluid that you add to them will be additional fluid that's leaked out, okay? Mucolytics. Do you guys have any of these in your rigs? Acetylcysteine? No. We have them in the ER. Even that and like guaifenesin, which is over the counter, it's a cough expectorant. You don't want to use these on these patients. That's not actually what's going on with them. They're actually having problems with opening up their airways. It's not that they have a whole bunch of mucus or a mucus plug in there. It could be, it could be later on, down the road, these patients have like a huge mucus plug, and as soon as that comes up, then their asthma and their breathing is actually a lot better too. What about sedatives or sedation in these patients? What do you guys know about that? Right, right. We don't want to do that any more than it possibly is right now. What about antibiotics? I didn't talk about this, but there's no infection that's going on. All right? This is just an inflammatory process that's causing constriction on the airway itself. There might be bacteria that's going there that antibiotics can help with. More than likely, probably not. Okay. Now, if they come into the ER and then we shoot an X-ray and it seems like there's maybe pneumonia going on, they have an elevated white blood cell count, and maybe that is contributing to their asthma exacerbation, great. Then we'll start antibiotics. We're just willy-nilly just kind of starting antibiotics. We usually don't do that. Okay, so I talked a little bit about beta agonists. The most common one is what? Albuterol. Okay, it's the most effective bronchodilator. It's a treatment of choice for the management of acute asthma. It's aerosolized. It's greater efficacy, less chance of side effects if it's aerosolized. It's also available as a syrup for little kids too. Probably don't see it often. It's also available as a tablet too. So like I alluded to at the beginning of the presentation, these oral therapies, like albuterol as an oral therapy, are not that effective because most of the time you have systemic absorption. You don't get the immediate response that you do with a meter-dose inhaler or a nebulized treatment. And with the systemic side effects, you have greater chance of switching your K, your potassium, from outside the cell, inside the cell. Okay? And it can lead to hypokalemia outside the cell. You can have changes in your blood sugar itself. You can have tachycardia, and then you can actually lead to cardiac dysrhythmias, but that's at really, really high doses. Oh. Yes?
Is it because it's a mild diuretic, or how does it actually lower the potassium?
So the potassium is lowered because albuterol actually binds to the beta receptor. And the beta receptor is actually part of the sodium potassium ATPase pump, which is a pump that lives outside the extracellular wall, but it actually transfers potassium inside the cell. So your normal cell has what? Higher potassium outside the cell or inside the cell? Inside the cell, right? And it's lower outside the cell. What about sodium itself? Sodium's higher outside the cell than inside the cell, right? They're opposites. So, and the reason why they stay opposites is because of that pump, that sodium potassium ATPase pump. So if we give them albuterol, which is a beta agonist, which binds to this receptor site, and it starts pumping that back and forth, we're going to cause a shift, okay? Now, the sodium itself, because it's higher outside the cell, can be shifted a little bit more, inside the cell. But because so much of it is outside the cell, you're not going to see a change so much. But because potassium is so much lower outside the cell than it is inside the cell, and you start shifting some of that potassium inside the cell, your potassium can go down. Does this make sense? You want me to go through it again, or you think you got it? Good? Okay. So that's actually a treatment too. So say you have a dialysis patient that's coming in that has missed 3-4 days of dialysis, and what's the one thing you start thinking of? Their potassium's really high. Okay? EKG shows a whole bunch of changes. All right? What are some of the things that you can do? I'm sort of going outside of our lecture here, but what are some of the things that you can do that shifts potassium from outside the cell to inside the cell? Okay, all those things do that. Yep. The calcium itself doesn't cause a shift so much. That actually just stabilizes the myocardium itself, and then by stabilizing the myocardium, hopefully it'll help alleviate some of the dysrhythmic effects that's caused by the hyperpotassium or hyperkalemia. Okay, but the dextrose and the insulin, that also binds to the sodium potassium ATPase pump, and it starts pumping things inside the cell. Beta-2 agonist is also another thing you can do that. So you give them like a huge dose of albuterol, like 20 milligrams via nebulizer. You hook them up, let them nebulize it over 1 hour, maybe a little bit longer than that, and that's going to pump the potassium from outside the cell to inside the cell too. Same thing. Okay? But all you're doing right there is you're just tricking the potassium a little bit to go inside the cell, just so you can get rid of this dysrhythmias that the patient's actually having. In the long run, I mean, the patient's going to have to go to dialysis, okay, to get rid of some of their potassium. Questions at all before we move on? Okay. So your beta-2 agonist, albuterol, how often do you administer these drugs? You tell me. Repeated dose. Okay. Right. Good. Good. So what kind of doses do you usually administer? Now, I understand some of this kind of depends on how long that you're actually going to transport the patient in. So if you're 10 minutes out, there's no sense in opening up like 4 different neb treatments, and putting 10 milligrams of albuterol in and having them nebulize it in all the way into the hospital. You're probably only giving them like 1 treatment. But if you're 45 minutes, an hour out, you may give them an hour long. It just depends. It also depends on the patient itself. So I've sort of broken it down here for you. Usually the adult dose is somewhere 2.5. We've given bigger doses. I mean, that's sort of just, starting. You can hook them up to 10 milligrams, give them a continuous, an hour long, dilute that out with normal saline, that's fine. Usually pediatrics, less than 5. It's a weight-based, but usually sometimes they give around 2.5 or something like that. Is that pretty much according to your protocols, or do you guys have 1.25? No. You do?
1.25 and then double the second dose, and then same thing that we had doing.
Okay, okay. Now, usually, I think it's a couple slides down. I think it's like 0.15 milligrams per kilogram, but then it's rounded to the closest nebulized, size that you have. So, on the really, really small ones, your 1.25 albuterol would probably be the appropriate size. So, side effects, I've just highlighted them again. Most of the time, you'll see these. The bigger the dose that you give, the more side effects that you're going to have. Okay. Even though you're giving it via nebulized, and even though the drug is actually going right to your lungs, you're going to get some systemic absorption of that. Okay. Elevated heart rate is common when lung function actually improves. So not always caused by meds in this case either. So I talked a little bit about where the beta receptors actually, or the beta agonists actually bind to the receptors right here. This is just more instruction about where those receptors are. It's a pretty big receptor that kind of is a transmembrane receptor, so it both transports things from outside the cell and inside the cell. It's what we call polymorphic, though. So let me explain this. You may have 10,000 receptors in your body. Okay. Polymorphic means that maybe some of those receptors are a little bit more responsive to a beta agonist and some aren't. So 10,000 receptors in your body, you give an albuterol treatment, maybe only 1,000 of those respond to that albuterol treatment. There's plenty of drug that's floating around itself, but not all the drug binds to these beta sites as closely and as tightly as other beta receptors do. Okay? So I want to explain the difference in between our catecholamines that we have in our body and how those work on our beta receptors and how albuterol, which is the most common beta agonist, works on this receptor itself. Now, when I start talking about drugs, most of the drugs you don't give a drug to somebody and it's just all of a sudden they get this new function, going on in their body. Most of it kind of potentiates a function that's currently going on in their body already. Okay? We're just dilating the bronchioles even more. So most of the time in these asthmatic patients, they actually have some catecholamines, specifically like epinephrine, that's released in their system that's probably causing some bronchial dilation. Okay? We're adding a beta agonist which doesn't work as good as epinephrine does at the sites itself, but it actually can do a pretty good job at potentiating and opening up the bronchioles. Okay? Does that sort of make sense? Did I explain that all right? I've just sort of written down how much these beta agonists work on the specific receptors itself. Some of these drugs work better on the receptor site. Other ones don't work as well. So Phenobarbital is probably the most potent. Albuterol is second. And then terbutaline, which I'm not going to talk about too much, doesn't work as well. Purbuterol and then salmeterol is not as likely to work on the beta 2 agonist receptors. I may have skipped over this a little bit, but there isn't anything that we give that is just a pure beta agonist. These drugs that we're giving for asthma are specific beta 2 agonists. Do you know why they're specific beta 2 agonists? I think Eric touched on this on his lecture. Beta 2 receptors in the lungs, right? Okay. Do you know where the other beta receptors are at in your body? What's metoprolol? What class of drug is that? Beta blocker. All right. So that works primarily on the beta 1 receptor. Okay. So we got a beta blocker, and now we have a beta 2 agonist. So the reason why there aren't any beta 1 agonists is because they work too much on the heart itself, and when they would cause increased heart rate itself. We don't really want that. We want just a specific beta 2 agonists that work on the lungs that cause bronchial dilation. Okay? That's why you see sometimes patients who maybe have COPD or asthma, and they say, I can't take a beta blocker. Because they take a beta blocker, a systemic beta blocker, and maybe they have another drug on board that is actually helping keep their airway open. They take a drug like propranolol. Propranolol is a non-specific beta blocker. Works on both beta 1 receptors and beta 2 receptors. So you're going to get blockade of these beta 2 receptors, some of them that are in the lungs. So you're going to compromise their lung function just by trying to improve or minimize their heart rate itself. So some of the ones that are more cardioselective beta blockers, they work just specifically on the beta 1 receptors. Does that make sense to everyone? Okay. So I'm going to talk a little bit about albuterol, and that it's a mixture. It's a racemic mixture of 2 separate drugs. And this is sort of transition into where Xopenex actually came from. So if you look at albuterol, its molecular structure, you would see one image of albuterol, and you'd see another mirror image of albuterol itself. Okay? When they did research on albuterol, they found out that actually it's not the 2 mirror images that actually cause the bronchial dilation and actually hit on the beta 2 receptors. It's just one of the mirror images that hits more on that receptor. And so when they studied it and they came up with a drug, they synthesized just one of those mirror images, and hence you get albuterol or Xopenex. Okay. So in chemistry, we talk about there's an R and there's an S enantiomer. I don't really expect you guys to know that, but if you ever hear that, that's actually the 2 different mirror images of the structure itself. So Xopenex came after they developed albuterol with the hope of having less tachycardia, less side effects associated with it. But if you ever realize the dose in which you would give of the albuterol is approximately half of what you would give of albuterol. So your normal dose for Xopenex or albuterol is what, 1.25 milligrams? You guys ever have albuterol in your rigs? No. No. Okay. But it's 1.25 milligrams for an adult dose. An adult dose for albuterol is 2.5 milligrams. Chronic administration of a beta 2 agonist. Have you guys ever picked up a patient in the field and just said, you know, I've been using my albuterol inhaler for the last 3 days, and I've been using it today, and it just doesn't work anymore? You guys hear that? So do you guys know what that's actually from? What's causing that? So when you're managing asthma, there's like acute breakthrough medication that you would use as like a rescue inhaler, and that's the albuterol. Okay. Other drugs that you can give to patients like Advair are more chronic medications that patients have to stay on for usually the rest of their life, maybe just a period of time until their asthma calms down. It depends. But within Advair, there's actually a steroid, specifically a corticosteroid. Okay. Corticosteroids can actually desensitize patients. So sometimes patients, when they use this beta 2 agonist over and over and over again, their receptors itself get almost like down-regulated to the point where they don't respond as well as what they initially did at first with that first albuterol inhaler. So if you give them a low-dose steroid, it actually helps decreasing the binding of the affinity of the beta-2 receptors and actually desensitizes these patients so the albuterol can work a little bit better too. It also strengthens the lungs and it decreases the amount of inflammation that's going on, which also helps open up the airways even more too. So corticosteroids can be given a couple different ways. They can be either inhaled or you can give them systemically, okay, to these patients. If you start using chronic beta-2 receptor agonists, the administration becomes to the point where they develop like a tolerance almost to the drug itself. So they use it, it's not going to work, okay? Usually it takes about a week for this tolerance to sort of develop. So if a patient's, initially they start using the albuterol and it works great on them. And after a couple days, maybe a week down the road, they start using it more and more and more each day. Their tolerances are going to get better, but they're not going to get the rescue breaths that they actually need. So, I was talking a lot about asthma, okay? But albuterol, you can actually use it for COPD. You can use it for acute bronchospasms, maybe by bronchitis. Patient comes in, they maybe get an antibiotic, but they also get an albuterol inhaler to help open up their airways. And like I said, it's off-label use for the treatment of hyperkalemia, okay? Avoid use in patients who maybe have an allergy to albuterol or salmeterol. I'd probably use it cautiously in patients who have a history of dysrhythmias or have AFib. You probably don't want to load them up on a big dose of albuterol. You're just going to cause their heart rate to go up even more. The more albuterol that you give to patients, even though it is a beta-2 receptor agonist, sometimes that can cross over and actually can cause the heart rate to go up too. Some of the other side effects that you can see: fine tremors, anxiety, headaches, muscle cramps, dry mouth, palpitations. Those are all side effects of it. Dosage range, I was saying a lot of like 2.5, but you can go up to 10. You can even go up to 20 milligrams if you want for severe asthma attacks. PEDS, that's usually 0.15 mg per kg, usually rounded to about 2.5 milligrams via nebulizer. And these are how all the different ways the albuterol is actually available. Any questions about albuterol before we move on? Okay. Terbutaline, do you guys have this at all? Riggs? No. I haven't used it in years, I think. I don't think. Mark, have you ever used terbutaline?
Only in the hospital.
Okay.
But otherwise not free.
It's pretty much the same activity. If you saw the slide on the bottom, it's a beta-2 receptor agonist. You're going to have the same activity as you will albuterol. It can be given subcutaneously, orally, or by inhalation. The effects of it are a little bit different in the fact that they can be delayed from 1 to 2 hours, which albuterol you usually see right away, the effects. Okay. Along with albuterol, I'm going to talk a little bit about anticholinergics. You're probably familiar with ipratropium or Atrovent. This is another agent that can be used to bronchodilate patients, but it works on different receptors than your beta-2 agonists. So what receptors does it work on? Anyone know? It works actually on the muscarinic receptors, okay? So you'll hear it a lot as like an anticholinergic drug itself, okay? You don't get a lot of systemic absorption of it because it's a pretty big molecule itself. It probably has a lot of history for use in asthma. You probably don't see it used in asthma as much as you do like a COPD or COPD exacerbation. It actually doesn't have an FDA labeled indication for asthma itself. The mechanism, like I said before, it blocks your muscarinic acetylcholine receptors in your smooth muscle along your airway, and thereby blocking those muscles, it helps to bronchodilate, okay? Most of the time you'd always use it in combination with an albuterol. It's available commercially as a duoneb, okay? A lot of times medical professionals get confused and they give duonebs over and over and over and over again to patients. They're not going to get, these patients aren't going to get benefits if you give a duoneb over and over and over again. The ipratropium itself is usually dosed about every 4 to 6 hours itself. So if you give additional drug on top of it, you're not going to get any benefit. If you give more albuterol on top of it, you will get additional benefits itself. But the ipratropium itself, you're not going to get any benefit. Does that make sense to everyone? Okay. Side effects, pretty minimal with this one. Sometimes you see dry mouth, skin flushing, and other side effects are usually pretty minimal itself. It's available as a nebulized solution or as a meter dose inhaler. And then here's your dosing right here. Usually in adults it's 0.5 milligrams, which is equal to 500 micrograms. You should be easily converting that back and forth between micrograms and milligrams. In pediatrics, it's anywhere from 250 to 500 micrograms every 4 to 6 hours. And then in the infants, it's 125 to 250. Does this pretty much match what you guys have, what your dosing is? Okay. So anticholinergics, specifically the ipratropium, you're going to have a longer duration of effect, anywhere from 4 to 6 hours. Like I said before, this isn't something that's usually used in asthma as much as it is like COPD, chronic bronchitis, etc. There is a long-acting anticholinergic drug by the name of tiotropium or Spiriva. You guys ever seen this before? Yeah? Heard of it? It's a green inhaler. And you actually have to take a capsule, put it in the inhaler, spike the capsule, and then you would inhale it. So it's a little bit different. It doesn't have propellant in it itself, so it's not a metered dose inhaler. It's more of a dry powdered inhaler itself. After one inhalation, there can be somewhat or some of the medication still left in the capsule, so it's recommended actually that patients take 2 breaths of this inhaler. Because it's a long-acting one, the half-life is a lot longer, and usually it's dosed every 24 hours. You can actually overcome patients who are saying like, well, I'm on Spiriva at home, and I took my dose today, but I'm still having difficulty breathing, okay? And you pick this patient up in the field. What drug do you give them? Do you just give them straight albuterol? Do you give them a duoneb? What do you give them? I'm going to give you a scenario. What do you think?
Albuterol.
Give them albuterol? Okay. What does everyone else think? You want a duoneb?
You know, because if it needs a little faster to get going with the ipratropium, then maybe, I don't know.
Okay.
I think the albuterol could put that in there if you want to get something that feels going.
Okay. Yeah, your response is not as quick with the anticholinergics, and it can take about 30 to 60 minutes. Okay. There really isn't a right answer. Both of them are right. You can give a duoneb. You can just give albuterol itself. It doesn't matter. Now, the ipratropium that you actually give, what it'll do is and the quote-unquote bursts that they receive. After so many steroid bursts within a year, sometimes patients can get increased risk of having decreased bone mineral density. So it can lead to osteoporosis, osteopenia. Specifically, patients that are on like chronic steroids, like your rheumatoid arthritis patients. They have a lot of inflammation issues. Sometimes steroids can kind of get the inflammation under control. It's difficult to get them off the steroids, and then sometimes you'll see them with a really round face. Moon face is something that's specific to steroids. Sometimes you'll see psychiatric disturbances, and you can see these actually pretty quick associated with steroids. Sodium and water retention. That has to deal with the mineral corticoid effects of these steroids themselves. So some steroids actually can make you retain more sodium and water than other ones, but chronic administration of steroids can lead to this. And sometimes you can see weight gain, not weight gain specifically associated with the water, but you can see the central redistribution of fat, and you'll see these abdomens are really large while being on steroids too. So the specifics, methylprednisolone, usually this is the one that you guys would carry in your rigs. It's the most common one. Indications: allergic reaction, asthma, COPD, cortisol production. Long-term use can have some immune suppression. Specifically, these patients that are on autoimmune diseases or that have autoimmune diseases like rheumatoid arthritis, Crohn's disease, or have maybe like a heart transplant, kidney transplant. Their new protocols are trying to get them off of the steroids themselves, but patients who have had a transplant a long time ago maybe are still on these steroids themselves. They can lead to increased ocular pressure and can lead to glaucoma, GI ulcers, and like I said before, osteoporosis. So how fast do you normally give methylprednisolone in the field? Pretty quick? 1 to 2 minutes IV push, right? So when I say methylprednisolone, is there only one type of methylprednisolone, or is there a couple types? It's a couple types actually. So take a look at your vials really close. So there's a sodium succinate that can actually be given IM or IV. If you give it IM, absorption is pretty quick. IVs also starts working pretty quick. There's actually a methylprednisolone acetate. It actually doesn't come in the active vial, so you don't push the solution down and then reconstitute it. This actually already comes in solution itself. So that is actually something that can only be given IM. You can't actually give it IV. It causes a lot of burning, patient. Okay, it's more of a sustained effect to these patients. You can actually give it in a specific joint. Maybe if you're having some knee inflammation, you can actually give this methylprednisolone acetate specifically into that knee joint, and it can help with the inflammation itself. Other ways you can actually give this, you can see tabs. Methylprednisolone as tabs. Most commonly, it's a methylprednisolone dose pack, which is like 7-day course where it's tapering down. Monitoring of patients, you always monitor for blood pressure. Not that common, but you can have some heart rate changes. Most of the time it's associated with whatever's going on with the patient, not specifically that you're giving them corticosteroids themselves. Nausea, vomiting. Specifically, if they take it as an oral tablet, it can be really hard on the GI system itself. It can lead to vomiting on those patients. What are typical doses that you give of this drug in your field? 125? Okay. Yeah. I mean, normally it's a lower dose, but usually the first dose, we always give them like 125 even in the ER. If you guys don't give it in the field. Okay. Pediatric doses anywhere from 0.5 to 1 milligrams per kilogram IV dose. So Just make sure you got an accurate weight in the patient. If you give it a little bit too high, that's fine. I mean, like I said before, everyone has cortisol in their system itself. These steroids are going to be converted into cortisol itself. So, dexamethasone. Does anyone have this? Yeah. What do you primarily use the dexamethasone for?
After we've tried everything else, and if it looks like our transport time is a bit extended, maybe I saw that too, which will 10 or second, or not second, but depending on the size of the person, 20 to get Decadron.
Sure. Decadron is more of a longer acting one. It'll stay in your system more. It's usually, even though it says every 6 to 8 hours, you can usually dose it about twice a day. Like I said before, it works good for controlling inflammation. Also helps control if there's any sort of CNS inflammation that's going on. You can get that under control a little bit better with dexamethasone. Dexamethasone actually has helped with nausea and vomiting also. A lot of times you'll see it given prior to giving like chemotherapy. Chemotherapy that's really hard in the GI tract and causes a lot of nausea, vomiting. They'll give a 10 milligram dose, sometimes a 20 milligram dose IV of dexamethasone. You'll see a lot in the ER used for croup in little ones. And then you'll also see it in meningitis, pharyngitis, and like I said before, as an antiemetic. So adult dosing is anywhere from 10 to 20 milligrams. Pediatric doses is actually the same. It's 0.15 to 0.6 mg per kg per dose every 6 to 8 hours. So how fast do you push this one? Really, really, really fast? Not fast? The bigger doses you push a little bit slower, and if you have a small bag, you can actually dilute it out, and you can run a little bit slower. Has a weird side effect. It causes perirectal discomfort if you push it too fast. I don't know where that comes from, but I've heard of it happening on patients, and that's something that you just want to push the drug kind of slow with. It's more for sustained effect. Yeah, yeah. I've heard of actually them nebulizing dexamethasone too, and that you can use for croup too. It's more of it's a thought of getting the steroid into the lungs itself versus like giving an IV and then having it circulate around their system. In pediatrics, we've given it orally before, and what we've done is we've taken the injectable drug and we've diluted it in like cherry syrup or just apple juice, and we've just given it. And there's no problem with that. The IV formulation itself actually has very little taste itself to it, and some peds actually just take it straight and they don't even taste anything. It's such a small volume itself, and sometimes it's easier to get that small volume in these little kiddos to help with things like croup. Questions at all? So here's an example of giving an IV drug orally, which you won't hear at all about giving an oral drug IV. Never, never, never. So, and that's going to lead to something we're going to discuss a little bit later. Hydrocortisone. So hydrocortisone also gets converted into cortisol in the body. Most of the time you'll see it used for like cortisol replacement in like stressed patients that are in the ICU. We use it as like a cortisol replacement in these patients. They also it's pretty powerful anti-inflammatory effects. Usual dose is around 100 milligrams, and it has like the same vial as your Solu-Medrol does. It's like an active vial, which you would kind of push down and solubilize the powder itself and then draw it up, and you can give it either IV, PO, or IM. But there's tablets itself that you can give PO in these patients. So, back to talking about asthma. what are some alternative therapies for asthma? Aminophylline, this is an old drug. Gets converted into theophylline. Patients sometimes are on theophylline as an outpatient. Most of the time you'll see that for like COPD or chronic bronchitis now than you'll actually see for asthma. It's not recommended for a couple of years. Do you guys have IV magnesium in your rigs? Mag sulfate? That's what I'm talking about, mag sulfate. Have you guys ever used that for asthma patients or difficulty breathing? You can use it for that, okay? It causes a bronchodilator. It's a bronchodilation, opens up the airways even more on these patients. So it's not going to be your first line drug, you know, but it's something that you're going to reach to even after something else has already failed. So you probably want to try Albuterol probably first. Ipratropium, reaching for steroids, still not working. You know, call. Maybe you can get an order for magnesium sulfate. Give it. So what are some side effects of magnesium sulfate? What's that? Hypotension. You gotta watch that pretty quick. You don't want to slam it in. Especially those little vials that you have. Dilute it out, put it in a mini bag. You guys have the premixed bags? Or just the little vials? Yeah, draw it up, give it slowly. I would say probably at least 10 minutes or so, if not more. 30 minutes is a pretty optimal time, but sometimes if you're really struggling at getting the airway opened up in these patients, you may give it a little bit quicker. Just watch the hypotension, because it's pretty profound.
Is that why when I'm giving it for eclampsia, I'm giving it fast? And then I'm problem. Is that why? Because of the reason for eclampsia?
Yeah, they're normally hypertensive.
Right.
Right, so you don't have to worry about that too much. And
I got nervous about it.
yeah, yeah, the doses in which you would give for eclampsia are like, 2 to 4 grams per hour on these patients, I mean, yeah, and you titrate up, and it will. Did it bring the blood pressure down a little bit? Yeah.
But I asked the doctor, I said, I don't think I want to do this. Then he explained it out, but I didn't want to do it. It's too high.
Yeah, you get pretty profound hypotension with mag sulfate. So that's, sometimes like in the hospital we have it already diluted. Okay, in our code carts we have the vials itself, and then we'll draw it up in a code and we'll probably dilute it out. If the patient doesn't have a pressure, it's nothing we can really do. Hypotension isn't really a concern if we don't have a pressure in the first place. But some of the other things that you can get some facial flushing in these patients. Yeah, if you're going to give mag sulfate for preeclampsia, the doses are pretty big, and the patients are usually hypertensive, so you don't have to worry. You have to worry about it somewhat, but you don't have to sweat as much about causing hypotension in those patients. Helium or Heliox, have you guys heard about that for treating asthma? Do you guys ever use it? No? It's debated how much actually effective it is. It's a treatment out there. I wouldn't turn to it as the first line therapy for treating asthma, but it definitely is a treatment itself. And now ketamine comes around again. You guys talked about that in your tox lecture. So what is ketamine? Horse tranquilizer. All right. Yep. Works good for birds too, believe it or not. Yep. What else? You're not going to be treating horses, though, are you? Treating humans. So what are we using in humans? Pain management, sedative. What's its mechanism of action? Dissociative effects. Works on NMDA receptors. It's not going to work so much on the opiate receptor, the mu receptor. Okay. You're going to get this dissociative effect to these patients, so watch for it. All right. You might get some nystagmus, watching their eyes jump around a little bit after you give it. The dose in which you would give on these asthmatics is not something that you would give for like a conscious sedation or something that you're going to intubate these patients, okay? You're probably going to give them a little bit smaller dose, okay? With ketamine, it's not going to wipe out the respiratory drive as much as like a benzo would, okay? And you're actually going to get some bronchodilation in it too. All right. Obviously, this is not a first-line therapy for treating asthma or COPD, okay? This is way down the line. So you're not going to be giving it willy-nilly in the field, and you're definitely probably going to call to get an order for it, okay? But I just wanted to cover a little bit. No. So ketamine, control 3 substance, okay? Not as strong as a control 2 substance, which is like your morphine dilaudid, but still a control 3 substance. So highly mandated and controlled by what? The DEA. So always be careful on who you're going to give it to. Always want to document how much you gave. And if you don't want the DEA knocking at your door, don't give it to your friends. Children less than 4 years old may be at greatest risk for respiratory failure. Okay, these are sometimes the patients that you're picking up in the field for acute asthma exacerbation. They're the patients maybe that you want to give a face mask to. Okay, you want to properly fit the face mask around them so the drug actually gets in their lungs and their system, and with the face mask it helps deliver the drug appropriately. Okay. I don't know that answer. I don't know that. But the amount that you would give is a lot higher than what they're actually giving. You know, if you figure your meter dose inhaler, they can get up to 50% of the drug actually in their system itself. And what you're given via nebulizer is anywhere from 4 to 15% of the drug that's being nebulized the patient's actually getting. So a really, really small percentage of that. But I don't know that answer. Mark, do you know by any chance?
I do not. No.
Questions at all? Okay. Talking a little bit about epilepsy. So epilepsy is a common neurological emergency associated with brain damage and death if it's not treated appropriately and if the patient keeps in their status epilepticus state. Okay. Generalized convulsive status epilepticus. I'm going to abbreviate a lot, so you'll see GCSE repeated a lot throughout this lecture. Okay. Most episodes actually occur in patients who actually have no history of epilepsy. So this is something new for them. Sometimes you'll see it in patients who are going through withdrawal, some sort of metabolic disorder, current illness, etc. And this table sort of highlights that. So type 1, they have no structural lesion itself that's causing the epilepsy, but there is something that's going on infection-wise, alcohol withdrawal, or unknown cause. Type 2, this could be anywhere from a CNS tumor, CVA, drug overdose, a bleed somewhere that's going on, or a trauma that's actually causing it.
What does the APD stand for?
What's that?
The lower APD levels, what does that stand for?
Anti-epileptic drugs. Yeah, good question. So with all anti-epileptic medications, most of the time you can get a level on these drugs. You have to be in a certain level actually to have your epilepsy controlled or seizures controlled. If patients are not taking it on a regular basis, they skip maybe a couple days, their levels can actually drop, and that can lead to a seizure itself. So usually what's happening that's causing seizures is somewhere in the brain there's something that's telling there's this excitatory impulses that's going off. And normally there's these inhibitory impulses that can sometimes suppress these excitatory causes. But in certain situations, these excitatory neurotransmitters overcome these inhibitory impulses, and the patients can lead to a seizure itself. So all the drugs that we're using to control seizures themselves, they're going to basically inhibit these excitatory neurotransmitters various different ways, and thereby inhibiting these excitatory neurotransmitters, they're going to control the seizure itself. Okay? Most seizures last for, what, 5 minutes? Sometimes you see a patient, you can go on and on and on with a seizure. Okay? Treatment usually is immediate termination of the seizure itself. So what sort of meds did you use? I mean, we talked about them last time. Benzos? Okay. So either Ativan that you have in your rig, lorazepam, or midazolam, Versed, either one of those is fine. What about Valium? Can you use that if you have it? What if you don't have an IV started? Can you give it IM? What did I talk about Valium and IM before? Not effective, right. You get erratic absorption. Versed you can give IM, Ativan you can give IM, no problem at all. But you can give it rectally, diazepam. Rectally, that's no problem at all. Absorption's pretty good. So when you arrive in the scene, the patient's seizing, you give them a drug right away, get their seizure under control. The long-term desired outcome in these patients are usually to minimize or avoid the likelihood of a seizure down the road, get them on a medication, get them controlled, and hopefully they won't have it again. So first thing you do is what? Get vital signs, right? Assess the patient, make sure you got an airway, ventilation to be maintained. And if you're in the hospital, obviously you can check a lot of labs, but you probably want to do a finger stick on these patients too. Get a good history from them, see if they're diabetic or not. First line treatment for epilepsy, we talked about that, benzodiazepines. Treatment goals, obviously, to eliminate any seizures, minimize the side effects as much as possible. So that's something that we do with pharmacies and physicians. We try to get them on a medication that's not going to heavily sedate them, that they can manage their day-to-day life activities, and that can control their seizures themselves. So do you ever see patients that are chronically taking benzodiazepines for seizures? You use them all the time to treat them. Why don't you see patients taking them? Yeah, they're going to get sedated. Sometimes you'll see patients on them, specifically like clonazepam. That's probably one of the ones that you'll see patients take for seizures. It's the longest half-life of all the benzodiazepines. So that has a half-life of anywhere from 30 to 45 hours. So what does that mean? I talked about half-lives before. Tell me what a half-life is.
Loses half of its effectiveness, essentially, if that whatever might out.
You're on the right. So concentration.
Concentration, how long it stays in your body?
Not necessarily so. Half-life is what we talk about when the concentration drops from half of its effect. So if we had a peak, so if the drug peaked at a specific spot, so this is time along the bottom, and this is going to be concentration right here. So if we took a drug at this point, say clonazepam, a tablet, okay? Tablet's got to dissolve in our stomach, become powder, get absorbed via our bloodstream through our GI tract. It gets absorbed, okay? It peaks at this point, and then it slowly declines. Okay? Say our peak up here is 20. Okay? And say it reaches a concentration of 10 down here. Roughly 24 hours later. What's the half-life of this drug? 24 hours. The drug is still in our system, okay? It's not completely out of our system. It's still around here, okay? But half of the concentration is gone. That's the half-life. Okay? We usually dose drugs based off of the half-life. So, and usually a drug has to be in, like it's like a certain area to be effective. So say clonazepam is, it has to be at least above 8, a concentration of 8 to be effective. Well, we have to dose it about every 24 hours then. Okay? Now gradually this is maybe going to get a little higher, okay? Because here we didn't have any drug in our system. Over here we do, and we're given another tablet. Okay? All right, that's an important thing because we talk about it in the medical field, half-life, a lot. And if you really don't have that down, then you're going to kind of be lost a little bit. So, good. All right, so back to controlling seizures and why we don't use benzodiazepines. A lot of times patients get overly sedated on those. So we have to turn to something else. Okay. Phenobarbital. Does anyone have that in their rigs? No? This is an old drug. Okay. It is effective for controlling seizures. It's not the first line therapy. It's usually the second line after lorazepam, diazepam, or midazolam doesn't control the seizures. Then you would turn to phenobarbital. Most of the time you're already at the hospital, and the hospital actually has phenobarbital, and they will actually give the patient an infusion of phenobarbital. It's not very soluble in liquid, so we have to add this thing called propylene glycol to it, and that makes it actually soluble. Propylene glycol can be really hard on the veins itself, so most of the time we have to dilute it out for it to be less irritating to the veins itself. The reason why phenobarbital isn't used a lot is it can cause a lot of respiratory depression. It can cause a lot of sedation. It can actually cause a lot of hypotension in these patients too. So, mechanism of action, it actually works similarly to how benzodiazepines work. It's going to interact with GABA receptors itself, and to facilitate sodium channels, and to help with the inhibitory part of that neurotransmitter complex, because of that rapidly firing part of the brain that's saying, that's sending out signals, and we want to inhibit that to prevent any additional seizures. Pharmacokinetics, it has a really long half-life. It's rapidly absorbed regardless of the route of administration. It's usually given once a day in oral form itself. Most common side effects, like I said before, fatigue, drowsiness, sedation. Advantages, a lot of times you'll see advantages with phenobarb in the fact that it's cheap. Its kinetics with this absorption and this half-life, like I talked about over here with this benzodiazepines, it's pretty linear. So if the patient's still having seizures and you draw a level and their level is low, you can give more drug and pretty much twice the amount that you gave the first time, and you'll get double the concentration. It's pretty easy for as far as kinetics. The place in therapy and how you'll see it used most often is usually drugs for like neonatal seizures. Okay. Otherwise, you'll see other drugs, and I'll be talking about that in a minute. So people that you want to use it cautiously on is anybody who has any sort of alcohol on board. That additional alcohol on board can cause more CNS depression and can cause more difficulty breathing and apnea with breathing. It's that whole thing with synergistic effects. And I talked about that about 2 times ago. So who wants to tell me what synergistic effects are? Being hard on you guys today.
I used it this morning. Remember I talked about patients with a pulse, you don't use 2 antiarrhythmics together?
Stuff that enhances the effect of the other drugs.
Yeah. So it enhances what's already on board. So, good. So you get like so you get 1 drug on board, you add another drug on board, okay? And instead of what you would normally think that it would help in controlling seizures or CNS depression and sedation, you normally get like a 2. Here you might get a 4, okay? So not the sedation that you would see with one, not the sedation that you'd see with the other one, but when combined, you get a lot of sedation, respiratory depression, etc. So that's why you wouldn't use it with alcohol. That's why a lot of patients, that's not prescribed a lot for adult patients too. They'll be on phenobarb, they'll have a drink or so, they get really, really drowsy, really, really sedated, and to the point where they just can't function.
A lot of our inner city pharmacists are on peanut butter balls.
Peanut butter balls.
Peanut butter balls.
Yeah, it was a drug that was abused a lot back in, I would say, the late 70s. It has a lot of, when you get to the concentrations high enough, you can get some hallucinations and you get some sort of euphoria from it. It is a controlled substance. It's not as highly controlled as other ones. It's a controlled substance 4, but it's available as tablets, elixir, IV, or IM. Phenytoin or Dilantin. Have you guys ever heard of that? Okay. That's another one that you can use to either treat a seizure in someone that's difficulty managed, that you can't get them under control with a benzodiazepine like lorazepam or diazepam, and you want to give them phenytoin, that's fine. Usually it's always administered in the hospital or in the ER. The kinetics are kind of funny. You probably only hear this with Phenytoin, but I want to say it. It's Michaelis-Menten kinetics. Kind of different. So it's almost like if you would double the dose on someone. So say they're maybe not at their therapeutic level, and you double the dose on them, you get a 4-fold increase in their concentration. Yep. Almost like a logarithmic increase in their concentration. So it's a little bit harder to dose. In somebody who doesn't have any phenytoin on board or Dilantin, it's pretty easy to give them a dose. Usually your dose is anywhere from 15 to 20 milligrams per kilogram. It's usually given IV. It has a lot of problems with also irritating veins, so you want to make sure you have a really good vein, really good flushing vein. It has this propylene glycol in it too. It can cause skin necrosis. You don't want to give it IM. Think of it as Valium when you give it IM, erratic absorption. If you're going to give someone something to give them for seizures, definitely give it IV. At higher doses, you can get some nystagmus. You can get a lot of dizziness, drowsiness, ataxia associated with it. If you give it too fast, you can actually get some hypotension too. This isn't like a prolonged infusion. Normally when you give Dilantin or Phenytoin, usually it's like a 30-minute infusion. Pharmacy dilutes it already in the bag for you. If you're going to be carrying in your rigs, I definitely would encourage that. You don't have to filter it or anything like that. When patients are on it for, maybe they're not taking anything orally and they have to have some sort of supplemental dose of Phenytoin, usually it's given every 8 hours and the doses are pretty small. Usually it's like 100 milligrams. The fastest rate that you can actually give Phenytoin IV push is around 100 milligrams per hour. So small dose, 100 milligrams, or I'm sorry, 50 milligrams per hour, or 50 milligrams per minute. I'll get it right. 50 milligrams per minute. So your dose is 100 milligrams, so it's only going to be a 2 milligram IV push. So pretty quick. If the patient starts complaining about burning or irritation at the site, check the IV. Make sure you have it in right. Make sure it's not infiltrating. If it is infiltrating, then stop. If it's just something that the patient's highly sensitive to, maybe it's an IV in their hand itself, try to flush it with some additional fluid. Give it slower. That always helps. It's first-line therapy for primarily generalized convulsions, seizures, and partial seizures. So you'll see a lot of patients on it. Sometimes patients aren't on it for a chronic period of time. There are some other medications that are probably safer and they have less side effects associated with it than Phenytoin. So patients sometimes are put on it because of some sort of traumatic brain injury. Maybe they're at increased risk of having a seizure because they have a tumor and they're maybe resecting the tumor. Then they'll put them on Dilantin or Phenytoin for a short period of time. All right, Phenytoin. You guys ever heard of this? All right. The drug companies came out with a drug, Phenytoin, that's safer and less irritating on the veins itself. Phenytoin does not have propylene glycol in it. It's easier to get into solution, and you can actually give it faster. You can give it at a rate of 150 Phenytoin equivalents per minute, which is about 150 milligrams of Phenytoin per minute. It's less irritating to the fact that if you have an IV that's infiltrating, this one, there's no problem at all with this. It's a prodrug. It actually gets converted into Phenytoin over a period of time of about 7 to 15 minutes. That's short enough period of time that physicians will prefer to quote-unquote load patients on this anti-epileptic drug versus Phenytoin or Dilantin. Questions at all?
Well, what's your opinion on the effectiveness of Valium compared to Versed?
Valium to Versed.
Valium a little bit better, Versed better?
I don't know. I actually like I like Versed for seizures over.
We just have some guys that are picked up because of the Valium shortage, and we have Versed in there.
Yeah, Versed's being studied more and more now. I don't know if I've read anything that had Versed compared head to head with Valium for controlling seizures, but there's a study that came out. I probably told everyone about this, but Versed to Ativan, and it showed showed that Versed was maybe a little bit better. It was a little bit different. You couldn't really compare apples to apples because the routes were a little bit different. They were giving the Versed IM, and they were giving the Ativan IV, but the repeat seizures were dramatically decreased to the point where they could say that IM administration of Versed was a little bit better. But I mean, if you're gonna choose one, there isn't a wrong answer there. You know, I mean, any of those are acceptable. What do you think, Mark?
Well, plus two, I like the idea of what they're going through. I think with the amnesic effects with Versed versus the other two, I would, plus you got the nasal, I would choose that.
Yeah.
More versatile, I think.
Yeah, that's.
And it's faster, isn't it? I think.
Yeah, you can only if you're going to give it via nasal atomizer, it's you don't even have to worry about a route. And if you're worried about giving a drug IM and you want to atomize it, versus that's the way to go. You somewhat saturate the nasal pharynx though somewhat, and you can argue whether half cc or 1 cc is maybe to like the upper limit of how much you actually want to deliver a drug, nasally. But absorption's pretty quick. So, yeah. Yeah, not a wrong answer in that. Yeah, a lot of times their brain is scrambled so much, being that they went through a seizure. If you want to give them Versed, I mean, that tends to like knock out their memory a little bit more. I don't know. Sometimes they come around and they really don't remember anything. Sometimes they come around swinging though too, so kind of have to watch it.
How are we doing with the shortage?
There's a small amount of Valium that's been released. There's not a lot that's being released outside of that though. Versed is, there's a lot of Versed now, and there's more and more Ativan that's around now too. So those two drugs have pretty much gone off the shortage. I mean, there's hit and miss areas where you might not get as much as you really want, but at least there's drug there. So I just had a case in here. I might leave this case for you actually to talk about amongst yourselves. Just due to the time, I just want to get through the rest of the slides. So, want to change gears a little bit and want to talk a little bit about thrombolytic drugs. What's a thrombolytic drug? Right. We think about, generically as calling them clot busters. Yeah. If there's any sort of thrombus that's going on in their body, the thrombolytics are gonna break that up. The one that I want to talk about a little bit about is tenecteplase or TNCase. Have you guys ever heard of this or seen this? Yeah. Do you guys carry this at all? No. Okay. Which hospitals have you seen TNCase at? Okay. It's usually given in those areas that they don't have like a cath lab available. It's pretty much its only indication is for treating ST elevated MIs. Most of the time, those patients, they want to sort of rush them off into the cath lab and open up any sort of like blocked coronary artery. An alternative to that is to give them this clot buster or thrombolytic, which is TNCase. It actually is going to initiate fibrinolysis and breaking up the fibrin, which then is converting the plasminogen to plasmin. So it's this huge cascade that comes on when we talk about forming a clot itself. This particular drug actually starts to break up that clot itself. This one is more specific in the fact that it probably doesn't work systemically, and it doesn't help break up clots all over your body. This one is more pharmacologically specific to maybe just breaking up that clot that's causing that ST elevated MI and that blockage in the heart itself. So the patients itself that you want to avoid it in, anybody that's going through active bleed, anybody that's had a recent surgery, any sort of intracranial neoplasm, anybody that doesn't have controlled hypertension also, you want to avoid it in, any of those patients. If there's any sort of bleeding, yes?
Well, we threw a patient in for an outline that didn't have a gas bleed, and they gave it, and I was told that they were concerned, but we came into the loops. They were concerned, of course, but they still were going to take them to the cath lab, and they still could perform it. It kind of threw me off a little bit because obviously the contraindication.
So tell me a little bit about this patient. What when they flew him in, was he a trauma patient?
No, it was an MI, and they didn't have cath lab, and so dropped him off at Luke's and took him right to the suite. And I kind of was baffled. I wasn't quite sure why you could do that.
Yeah, I'm a little confused too, because normally they would say either this one or this one. In this case, they gave the thrombinolytic, and then they actually took him to cath lab. Maybe they were concerned that the clot was so big, or then they wanted to maybe dissolve part of the clot before they actually took him to cath lab. Yeah, right. Because I mean, once you start going in, you know, and performing like an angioplasty in those patients and stuff, I mean, just that procedure itself, there's a lot of risks, retroperitoneal bleeds, bleedings on top of it, you know, because they have to nick an artery and go up in there to actually shoot the dye in there. So that surprises me a little bit too.
The only one I've ever heard of, it just messed me up with lecturing and everything I've ever been taught.
Yeah.
Well, that could be, and I didn't know that. We took them all the way, almost like from Madison, almost.
Oh, you took them from Madison all the way to St. Luke's?
Well, came from Devil's Head and came in here, so.
That could be the reason then. They wanted something on board to sort of break up that clot before they gave it. But you also have to think about too, I mean, what if they give this drug and it's going to start breaking up clots, and then they take them to cath lab and they can't open up the coronary artery and put a stent in, and then, or what if there's multiple vessels that are occluded, and now the patient has to go to, you know, bypass surgery. So now they have this drug on board. Well, bypass surgery, they may be able to wait till the next day, and then the drug will be gone. But you always have to think about that.
It was given a lot earlier, but I heard that they, you know, I saw the report, which was threw me off, and I didn't like to ask too many questions.
Yeah,
With 2 letters.
sure. Yeah, that is a good question. Yeah, I mean, you look at the side effects of some of these things, and there's always like major bleeding associated with it as far as adverse effects. The T in case is a little bit more specific, like I said before, and it really only works on a lot of times the coronary arteries. That's really its only indication. So when you think about it in safety compared to the other drugs that I'm going to be talking about, that one maybe they feel a little bit more comfortable with. It's based off of weight, so you really have to get an accurate picture of how much your patient weighs, and then you have to measure out the dose itself. The maximum dose that you would be giving to these patients is 50 milligrams BIV push. Retaplase is another one that's a fibrinolytic. It has the same mechanism of action. It's really only indicated for ST elevated MIs like T in case. Side effects, you always want to watch for bleeding. Always want to avoid it in those patients that have had recent surgeries, traumas, anything like that where you might have bleeding uncontrolled but you don't know. They might clear them after they go to CT scan and determine that there isn't any bleeding and still want to give the drug. That's fine. The gold standard with treating ST elevated MIs and any sort of blockage is to rush them off into cath lab and open up that coronary artery that's occluded. So you won't see too much of this drug, especially when I think T in case is, I personally think T in case is a little bit safer to be given. The Retaplase actually has more bleeding, systemic bleeding associated with it. So, and just remember in all these patients too, you also have to be giving them aspirin too, and then is usually you start a heparin drip on those patients. The patient that you flew in from Devil's Lake, did you start heparin at all or no? Okay. Aspirin you gave them, or they already had aspirin on board? Okay.
Can you emphasize, you keep saying only for STEMI, I know why, but can you emphasize why you would not do it for just ischemic patients that have old closure?
Oh, are you talking about?
Or reopening them up? Fibrinolytic therapy, you don't want to give it for ST depression or an inversion, because when I am closing up, because I eat wrong, now
Sure.
I'm opening up.
Now you're going to drop your. I don't really know.
Well, what happens if you do that, it's contraindicated for, it's only for elevation. I'm having a new blockage. If you give it, because I have over the years blockages, now you open open them up. And what happens when they're lipid rich and you open them up, what does your body tell you to do? With a wound. Platelets, where are the platelets going to go with that wound in my coronary? That's why he keeps emphasizing only for stemming, not ischemia. Does that make sense?
Good, thanks. The other thrombolytic that I'm going to talk a little bit about is Alteplase, or TPA. And that's probably the most common one given now. It's not really for ST elevated MI, although it does have an indication for that. It's primarily used for ischemic stroke, acute ischemic stroke. Okay. You won't be giving this in the field. They have to go to CT, have a CT perfusion study done that shows that they actually don't have a bleed going on, that they're cleared, that they can actually get the drug itself. There's a lot of warnings and precautions. This one is not so specific to the coronary arteries, so that's why I say that you don't really use it for an ST elevated MI, but it gets systemic circulation, so that's why it's used primarily for ischemic stroke. In these patients, you always want to monitor for bleeding. Obviously, if they're going to run it, sometimes you may be transporting from one facility to another one after they give TPA. And there are some facilities right now that you will give TPA and they'll still take them back to do a procedure on them, even after they give TPA. And they'll try to open up the part of the brain that's not perfusing appropriately. Freighter's really good at doing that. They do a lot of like reperfusion studies, and we're starting to do that now, but they still have a lot of experience ahead of that. So, yes?
Actually, Bob Page in Missouri, who did a pre-hospital, very strict protocol, but they've been doing it for a while now.
Wow.
Kinetics.
Pre-hospital.
Yeah, and last time I talked to him, he said, because they're tested every month on the full protocol, but he said they had one incident where it shouldn't be given. Not devastating like that, but it didn't meet the criteria. They're actually,
Wow.
it's a little scary.
It is a little scary, right?
I think I'd be a little nervous.
Yeah.
Protocol or not.
Right. Yeah, because you have to think, I mean, you don't know on these patients if they have a huge bleed going on or if they just have an ischemic stroke going on until they come back from either MRI or CT scan. So, and giving it a patient that has a huge bleed going on, that's pretty devastating. That's going to be a mess. Your dosing, usually for ST elevated MI, is usually 100 milligrams over 1.2 or 1.5 hours. Here's your dosing for patients less than 67 kilograms. You can actually give it for a massive PE. We've given that on occasion. We've given it in two different ways. Here it says over 2 hours. We've given it over rapid IV push, but we have given that before. And then here's your dosing for the stroke also. So vial sizes, this is a dry powder stored at room temperature, so you don't have to worry about refrigerating it. So it could be something easily that you could carry around in your rig, reconstitute it, and then drop the dose and give. All right, told you I was going to be jumping around a little bit. Talk a little bit about mannitol and probably how it fits into therapy with managing elevated ICP, which is intracranial pressure. So you can actually use it for interocular pressure too, in those patients that have acute closed angle glaucoma. You can actually use it for reducing that kind of pressure too. You want to use it not in patients who are too hypotensive, have any sort of renal disease or sensitivity to mannitol. Mannitol itself is a huge structure of like an alcohol sugar. And how it works is actually, it works as an osmotic diuretic. Kind of similar to how like furosemide works, but a little bit different. Furosemide actually works on blocking the reabsorption of sodium and potassium via the loop of Henle, if you remember before. Mannitol itself doesn't work on any sort of receptors, doesn't block any reabsorption. What it does is it circulates around the bloodstream, gets into the kidneys, gets excreted via the kidneys, and then because it's a huge structure, it sort of disrupts the concentration in which other electrolytes are reabsorbed, and it actually increases the concentration in what's excreted via the urine, so it takes excess water with it. So it's something that works really good initially, but after a while of giving it over and over and over again, the body compensates for this osmotic diuretic effect. So it's really good at reducing excess water, pressure, and it really can help for these patients who have sort of like this acute rise in intracranial pressure. Now, if you don't have anything to measure the intracranial pressure, then you don't know if it's high or low. So you really have to think about, you know, the settings in which you're giving it. It's probably only in an ICU. But if someone has like a shunt that they can actually measure their pressure with, and they are an outpatient, then you would know that they have this acute rise in intracranial pressure. Dosage usually, it usually comes in a bottle. Sometimes you can get it in a bag. The range is anywhere from 20% to 25%. The dose in which you would give either adult or ped is 0.25 to 1 grams per kilogram. And you'd repeat that as needed for excess fluid or intracranial pressure. Monitoring, obviously watch for changes, nausea, vomiting, respiratory difficulties. This is a drug that isn't really stable that much in solution, so it crystallizes out. So once it crystallizes out, what the pharmacy does is it actually heats the vial itself in like a warmer, and when you heat it up in a warmer, the crystals go back into solution. When you're giving it via IV push or a slow infusion, you want to make sure you have a good flowing IV, make sure it doesn't infiltrate or has any sort of extravasation. And then you actually want to give it with an inline filter to make sure that if there's any sort of crystallization that's going on, those crystals don't get into the bloodstream. And it's not something that you can give actually at the same time as you're giving blood itself. What happens when you give it with blood is the crystals form kind of at Y site when you're giving the blood. So you want to wait until the blood's actually in, give it at a different IV site, etc. Okay, skipping around again. Did you guys ever get a lecture on Nemotop or Nimodipine? Does that sound familiar? Okay. Nimodipine is a calcium channel blocker. What other drugs are calcium channel blockers that we talked about? What's that? Cardizem, diltiazem. Right, good. This one's a little bit different than cardizem because it has a greater effect on the cerebral arteries. So the only indication in which you would use Nemotop is actually only for subarachnoid hemorrhages. And it's pretty good at reducing that arterial pressure itself. Things you want to monitor for: hypotension, sensitivity. If they have any sort of other allergies to a calcium channel blocker, you want to use it, not use it in those particular patients. The difference with Nemotop or Nimodipine and diltiazem is that Nemotop doesn't affect the heart rate as much as cardizem or diltiazem does. Okay? It's a different calcium channel blocker than that one. Okay? Now, most of the time these patients that they're giving it to have NG tubes or G tubes in. So what the nurse has to do is they actually have to take the capsule, pierce the capsule with a needle and a syringe, draw the drug out, and do that on a couple of them to get the dose of 60 milligrams. And then they would give it via NG tube or OG tube. So a problem that has happened is that when the nurse goes and spikes the Nemotop capsule, draws it out, is they've actually given an IV before. So before I was talking about dexamethasone and how you can actually give an IV drug orally. One time, that's sort of like a situation sort of specialized to dexamethasone. I also told you that you would never give an oral drug IV, and there's been numerous mix-ups with this medication. But usually given 60 milligrams every 4 hours. Like I said, watch hypotension, chest pain, palpitations, etc. Okay. I think that this is the last one. No, I got a couple more. Warfarin. This is a blood thinner. It's actually developed in Wisconsin. The WARF stands for Wisconsin Alumni Research Foundation. That's the beginning of WARF. If you go up to Madison and you go around the campus, there's actually a building. It's called the WARF building. That's where they did all the research for this drug. It's a blood thinner. It's going to be specific to clotting factors associated with vitamin K. It's kind of an anti-vitamin K. These particular patients, you don't really tell them not to take vitamin K. Once they get stabilized on the drug itself, you just want to keep their diet pretty consistent. Use it for long-term therapy and blood thinning associated with treatment of pulmonary embolism, DVT or AFib, patients that are higher risk of forming a clot, these particular AFib patients. You want to avoid it in patients who have any sort of active bleeding going on. Alcoholism, because there can be some drug interaction here, but on patients who are alcoholic, I mean, they're high risk for what? Falling, right? Falling down, hitting their head and stuff like that, and that's the last person that you want to have on Coumadin or warfarin. So, normal dosage is anywhere from 2.5 to 10 milligrams, usually once a day, and it's usually monitored by their physician office, the hospital, clinic, whatever, and they do PT-INRs weekly. And then as they become stabilized on their specific drug, they extend the period out in which they don't want to do a PT-INR every week, every 2 weeks, every 3 to 4 weeks, and then sometimes it's once a month. Questions at all about that? So there can be some what we call bridging going on. So patients come into the hospital, they have a pulmonary embolism. We treat them right away with shots like Volvenox, or we start them on a drip of heparin because it works quick. We know the drug's on board, it's thinning, it's preventing that DVT from getting any bigger, it's preventing the PE from getting any bigger. The body on its own is going to dissolve its own clot. We just want the blood to get thin right away. Warfarin or Coumadin takes about 5 days for it to build up in your system and start working. Because of all these clotting factors that we're actually inhibiting, they have really long half-life. So up to like 60 hours. So we give a drug and it may not work for about 5 days. Okay? We overlap that therapy. We keep them on a heparin drip. We keep them on Lovenox sub-Q injections while they're getting the warfarin tablets also. Any questions? Okay. Switch gears again, talk a little bit about paralytics. Now this is something I kind of threw at the end because I think everyone's kind of familiar with this. Succinylcholine, you guys have that in your rigs, okay? Do you guys have any other paralytics besides succinylcholine? Anyone have VEC? You have vecuronium also in rock? Okay. All right. So what's the benefits of succinylcholine compared to vecuronium or rock? Short acting. It's also faster too. So here the drug works in about 30 to 60 seconds. Vecuronium or rocuronium may take like 3 to 5 minutes or so for it to kick in. This is succinylcholine is a depolarizing neuromuscular blocker compared to a non-depolarizing. Does that make sense? The differences in between those? Okay. So patients that you probably want to avoid its use on, burn patients, patients with myopathies, history of malignant hyperthermia. That's something that we have like a specific cart down in the OR because they use a lot of succinylcholine. If they have any sort of case of malignant hyperthermia after giving succinylcholine, they have the drug that they would give to reverse that. So you want to monitor temperature. The temperature is spiking way up after you give it. You may have a case of malignant hyperthermia going on. Okay, especially with muscles, they may get really, really rigid afterwards. Side effects, the potassium may change a little bit, and that's sort of, it's sort of a weak contraindication for using succinylcholine. I mean, you guys in the field don't know what the patient's potassium actually is, so that wouldn't discourage you from using it, but you probably want to avoid its use on the inpatient side with anybody who's got really, really high potassium, because that potassium may get even higher. You can see some bradycardia with it. Have you guys ever seen that with Sux? Maybe, maybe not. Right. Yeah. There's a bunch of other things going on. Yeah. Here's your dosing. See if this matches what you guys usually do. 1 to 1.5 mg per kg IV for adults. Now, peds I put in here, but it's not really the drug of choice for peds. Why isn't it the drug of choice for peds? Not sure. I don't think it's that. I think it's a higher case of malignant hyperthermia with peds. So that's why they tend to use vecuronium instead of succinylcholine for that particular patients. So here I just highlighted fastest onset, shortest duration. So if you're not good at getting an airway established, the drug will usually wear off pretty quick, a lot quicker than your vecuronium or your rocuronium will.
So they would have more tendency for circulation then because of it? Disease in pediatrics?
No, not. I mean, everyone has the tendency for the fasciculations, according to succinylcholine. The malignant hyperthermia is where they have really, really high temperature, but it's not really associated with the fasciculation. It's sort of like that, the smooth muscle contraction, and then the increased temperature itself. So a lot of those patients are really, really rigid after you intubate them. And this kind of leads into the other thing too. I mean, on these patients that you're going to be giving a non-depolarizing or depolarizing neuromuscular blocker on them, what do you guys think about sedation in those patients? You're going to have to think about sedation. Because if you paralyze somebody and you don't sedate them, that's pretty mean. They might just come to your door next time you see them and just tell you how mean you really are. Vecuronium, that's another thing that you guys are probably pretty familiar with. It's a little bit different than Sux. It's a non-depolarizing neuromuscular blocker. You sometimes see it used in the ICU as a continuous drip. You don't see it as often as other things. Spelled that one wrong. Sorry about that. But you do see it used in our hypothermia protocol. And you'll see other non-depolarizing neuromuscular blockers too, with controlling the shivering in these patients too. You obviously want to sedate them, but if the sedation doesn't work and doesn't control their shivering, then you sort of give them a 1 dose of vecuronium for that. Patients that you want to avoid their use, anybody that's sensitive to vecuronium, use it cautiously in patients who have any sort of hepatic impairment. And side effects, again, bradycardia, hypotension. Here's your dosing for the adults. And the peds is usually around 0.1 mg per kg per dose. Is that usually what you're using for your vecuronium dose? Does everyone kind of know? Okay. So what's that called when you use 1/10 of a dose prior to using the Sux? Anyone know what that is? What is it? It's a defasciculation dose. Yeah. A defasciculation dose. And you can use that for rocuronium, you can use it for pancuronium, vecuronium, doesn't matter regardless of whatever ones you use. I've seen it used for VEC and I've seen it used for ROC, both of those. So what you do is you actually don't slam it in and then automatically just follow that right away with the sucks and slam that in. You would slam it in, let it circulate a little bit, minute, and then go ahead and follow that up with your sucks. So what's happening is the vecuronium is working on these neuromuscular sites, and it's binding to them, and it's preventing the depolarization. With the depolarization, you get the fasciculation. So that's why you put it in, wait a little bit, let it circulate, and then follow it up with the succinylcholine. Has anyone ever given the defasciculation dose of VEC or ROC before? Yeah? Small dose, right? Yeah. You're talking about getting your 1 cc or insulin syringe out and measuring that out just to make sure, and then maybe even diluting it with like a 10 cc syringe and then giving it since it's so small. So, good. Thanks for bringing that up. Pancuronium, you guys ever, no? It's not something that's used that much. You want to make sure that you use it cautiously in anyone who has any sort of kidney and liver dysfunction. Some of the new non-depolarizing neuromuscular blockers are a little bit safer, so you'll see them used instead of pancuronium. And vecuronium is actually probably used a little bit more just because it's a little bit more indicated in pediatric patients. So, cisatracurium or Nimbex? Has anyone ever heard of that? So this is a drug that you don't have to worry about dose adjustments with any sort of renal or, I spelled that wrong, hepatic dysfunction. This one is eliminated just like atracurium is. There's another drug that's atracurium. This is cisatracurium via Hoffman elimination. So it doesn't require hepatic or renal dysfunction for elimination of the drug itself. So a little bit safer in our patients in the ICU. We don't have to worry if their kidneys take a dive and they're on a continuous drip of cisatracurium. They may not wake up for a week. Not so. Okay? If their kidneys take a dive and their renal dysfunction really goes down, this drug is eliminated the same way regardless of how their kidneys or liver is functioning. So, questions at all? All right, thanks. Sorry I went over about 10 minutes.